Regresamos entonces, señoritas y caballeros. Vamos a ver un documental, pues precisamente esos estados afectivos bipolares. También se las comparto.
Program is sponsored by Eli Lilly and Company in association with the International Society for Bipolar Disorders. We live in a culture that celebrates extremes. Bigger, faster, louder, pushing ourselves to do more in a day, in a life. For most of us, the extreme is an occasional state, something we can control. But what happens when the extreme becomes everyday existence? For people with bipolar disorder, the experiences of daily life get pushed to the edges as their moods cycle from highs of productivity and energy to lows of deep sadness. This program will examine bipolar disorder through people who live with it and doctors who treat it. Because with proper treatment and support, people with bipolar disorder can live balanced lives.
Bipolar disorder is a primary mood disorder, and it's characterized by alternating periods of mania and depression. And it affects people's ability to function interpersonally with their jobs, in social situations.
I had irritability, I was happy, I was sad, I mean, up and down, two opposite ends of the spectrum, I had both.
I was processing something else in my own mind, which was, now that I know it was sick, it was illness.
It's something that affects your whole life. It affects your physical health as well as your mental health and everyone around you.
It's an illness that's characterized by distinctly opposite mood states, but also by mood states that can occur simultaneously.
In bipolar disorder, individuals swing from extremely elevated moods, called mania, to extremely low moods, called depression. In fact, bipolar disorder used to be called manic depression. Individuals may also experience a spectrum of moods in between, often including periods of normal mood. Certainly all of us experience a range of moods on a daily basis. But what defines bipolar disorder is the severity of these mood swings.
And so even though we might have all had feelings of being happy, and we've all had feelings of being sad, this is a brain chemical disorder of severe extremes of those that are beyond the person's immediate control.
The very phrase bipolar disorder makes us think of moods as two opposites, mania and depression. But the moods of bipolar disorder actually present along a continuum. The illness is often diagnosed according to severity as either bipolar 1 or bipolar 2 disorder. Bipolar 1 disorder is characterized by full-blown manic episodes that may include delusions or hallucinations and can result in hospitalization. Bipolar 2 disorder is diagnosed in people who have milder manic episodes that do not interfere with their daily functioning. Both bipolar 1 and bipolar 2 include episodes of depression. Regardless of severity, all bipolar disorder has the same origin. It is a mental illness rooted in biology.
We do know that the genes predispose individuals to bipolar illness. Now the question is, how do these genes bring about the symptoms of bipolar disorder in a given person? We think that is due to some chemical changes and perhaps some structural changes in the brain.
While there is still much to understand about bipolar disorder, doctors can usually make a diagnosis by looking at a patient's family history and clinical history, and conducting an interview.
In some cases, it can take 5 to 10 years before we realize that someone actually has a bipolar disorder. Sometimes people don't even seek treatment after the initial onset of symptoms. And if they present just with a depression, it could be many years before they have a subsequent episode. And if it's another depression, we could just think, well, this person has a recurrent depression.
Proper diagnosis is critical because bipolar disorder can devastate a person's relationships, career, finances, and in some cases, can even be life-threatening.
15 to 25% of people with bipolar disorder will attempt suicide at some point in the course of their lives. And if untreated, and that's an important piece of this, if untreated, up to 20% of people can successfully complete suicide.
This is a disorder that affects not just the quality of life, a person's ability to maintain a job and finish school and to maintain their relationships, but quantity of life.
To understand bipolar disorder, we must understand its two main mood states. We begin with mania.
Mania is characterized by distractibility, very easy distractibility, inflated self-esteem or an exaggerated sense of self-confidence.
As I went off on tangents and I couldn't get back to where I was before, I couldn't resume my focus.
There would be days where I thought I could write a great manifesto to change the world and bring about justice.
In some cases, a person could have grandiosity to the point of being delusional. Over 44% of people with mania will present with some kind of psychotic symptoms. And if the delusion is such that they think that they have maybe superpowers, have special relationships with important people, etc.
I wandered through the city, just really completely lost, feeling as though I was on some sort of spiritual journey.
The person with mania may also present with pressured speech, which means there's such incredible pressure to get the information out. They talk very rapidly and often in a loud, expansive manner.
My mind was racing so quickly, and it was so fascinating because I thought I was having wonderful insights into my thought processes, and it was like I could see the neurons and the neurotransmitters racing there.
Someone in mania may also engage in increased purposeful activity. They might have lots of increased energy such that they are cleaning the house all night long, they're painting, writing a book.
I'd start writing a new story, maybe start a novel, and then, after a week or two had gone by, I'd put quite a bit of time into it for that week or two, but then my ability to stay with it would just disappear and I'd be on to the next project.
Some people with mania will get themselves into difficult situations where they spend money that they don't have. They'll engage in sexual indiscretions and get themselves in financial, marital problems and job problems, sometimes legal difficulties as well.
I've done some pretty bizarre things in a manic state. I've overextended myself financially many times, sometimes frivolous, bizarre behavior, bordering on criminal behavior at times.
I was 17 and I was getting into some drugs and driving faster and hanging out with a lot of women.
They have increased energy to the point that they absolutely don't need to sleep. The mood can also be irritable, and that's where the person tends to get into a lot of trouble. They can get into physical altercations or verbal altercations because of their extreme irritability.
And I felt great. I didn't think anybody could stop me. I didn't think I could stop me.
He seemed very aggressive and confrontational. Really, I just wrote it off to this is our first major blowout. And I asked him to leave the home. And he had an apartment at his college. And so I said, you go to your apartment, you stay there, and please don't come back here for a while.
Sometimes mania does not present in such an obvious or extreme manner. Many individuals with bipolar disorder experience what is known as hypomania.
Symptoms of hypomania are identical to the symptoms of mania, except they're less severe. So we diagnose hypomania when someone has pressured speech or a decreased need for sleep or is speaking rapidly, but that those behaviors do not interfere with their day-to-day ability to get along.
Every summer I'd have a lot more energy. I'd start sleeping less, and I wouldn't have termed it mania. I didn't feel I was out of control. I just thought that I was the same person as I always am, with a lot of energy.
Episodes of mania can be triggered by environmental factors like lack of sleep and stress, but they can sometimes also be triggered by medication. Bipolar disorder is frequently misdiagnosed as clinical depression because many patients only seek medical treatment when they feel depressed. But for a person with bipolar disorder, treatment with antidepressants alone may push them into mania.
I was put on an antidepressant, and yes, it did cause a manic episode in combination with a lot of other things in my life. The first couple of weeks were okay. I was smiling, things seemed good, I was sleeping. 5 to 6 to 8 weeks later, within 8 weeks, I was in the hospital because I'd had that manic crash.
Contrasted with the energy of mania, the depressive phase of bipolar disorder can be debilitating. It is often this aspect of the illness that leads people to seek treatment.
I didn't understand. Why am I crying? Why do I not feel like getting out of bed? You know, there's nothing wrong with me. There's nothing wrong with my life, and I don't know why this is happening.
The symptoms of depression include persistently depressed mood, sometimes a mood state so low that people can't feel anything anymore.
Patients during depression tend to have difficulty concentrating. They also tend to experience tremendous amount of guilt, and often they feel that life is not worth living.
I almost attempted suicide. And on that day, I'd gotten as close as taking a razor and going into the bathroom. And at that point, when I realized that this was a life and death issue, I realized that I had to seek help.
I was depressed for probably 6, 7 months, and I just didn't tell anybody. So I just said, bottle it up, keep it inside.
I slept a lot more, kind of in a fetal position at times. Couldn't do my motherly duties like fixing meals. My oldest daughter prepared meals and took care of the kids for a while.
Why couldn't she just get her energy back? Why couldn't she just get that attitude back in line? Why couldn't she just make herself do what she used to do?
There are now at least 2 studies that have shown that, on average, most people with bipolar disorder spend most of their time neither manic nor depressed nor well, but rather having chronic, mild depressive symptoms, not fully treated. And that those depressive symptoms are one of the biggest factors contributing to long-term or permanent disability in people with bipolar disorder.
Along the continuum between mania and depression are other mood states. One of these is the mixed state, a combination of mania and depression occurring at the same time.
Typically what happens is that patient is experiencing this dysphoric, distressing, irritable kind of mood with a lot of anxiety. They also tend to have a lot of thoughts going through their head, but these can be, these are often negative kind of thoughts, which again are distressing to the patient. In addition to that, they also can have significant increase in their energy, and also they might feel very agitated as well.
With mixed mania, you don't get the euphoria that a patient with regular mania would get. You get agitated, restless, anxious, very jittery, very nervous. And on the other end, you've got this debilitating depression. So, like I said, the mixed mania is kind of a combination between the manic and the depressive side, where you're really high, you're buzzing, so to speak, but it's tempered by this awful negativity of the depression. It's kind of the worst of both worlds.
Bipolar disorder is also characterized by cycling from one mood phase to the next. These changes in mood can happen over a few days to a few months. Sometimes these cycles will even coincide with the seasons.
About 8 years ago, my father passed away, and immediately following his death, I went into a fairly severe depression. And that recurred the next winter, the following winter, and pretty much every winter for the next 4 years. Each summer, I entered into what was more definitely a manic state.
Even though we may have individuals who might have some manic symptoms at the same time as depressive symptoms, what's more typical is individuals are in a manic state, the elated or the irritable state, for a period of weeks or even days to weeks or even up to a month or even more. And at other times, we'll be in a depressive episode for a period of weeks.
Increasing awareness in the medical community and in the general public has led to better diagnosis and treatment of bipolar disorder. The road to recovery begins with accepting diagnosis, learning how to manage the illness, and drawing on the support of family and friends. Now, bipolar disorder can become a part of one's life, not life itself.
As much as this is a very important, severe illness, there is hope. It's not totally a devastating situation, that there are wonderful treatment options out there for people, and that people with bipolar disorder can lead very productive, successful lives.
I said, well, at least they understand that it does exist and there is treatment procedures. That's a very hopeful thing.
It was an answer to me. It was an answer to me. And I didn't feel any shame about this at all.
Bipolar felt like home to me. It felt like my title. Not like it's an award, but it felt like this is what has been hurting me, and this has been what is assisting me, and now I need to find a way to manage it.
One of the most essential elements in the long-term prognosis, how well do people do, not just in managing an acute manic or depressive episode, but how well do they do managing their illness over time, is the amount of support they get from family and friends. Now, that's not as easy as it sounds. This is an illness that can burn people out. It can challenge the integrity of close relationships. But I think it's important that family and friends understand about bipolar disorder so that they recognize, well, gee, this is behavior that's because of the illness.
Of course, my parents, they've been an immense support. When I was in the hospital, they came to see me every single day. They go to meetings put on by NAMI to help educate people about mental illnesses. So they're very informed as far as what this illness is, what are some of the signs that some sort of episode might be coming on.
We have a really incredible network of friends and family. She's got a great support system, I think.
We were very tempted to toss Michael away, to say, get out. We can't deal with this, you know, figuring it was drugs. Once we realized it was a mental illness, it was almost like a relief. We could bring him back and love him and look after him.
Like any medical illness, bipolar disorder does require treatment. This often includes therapy or counseling and medication. Medication is necessary because it manages the brain's chemical imbalances and can greatly reduce symptoms. Still, many people find it difficult to adjust to taking medication every day. They will often miss the energy of their mania or have trouble tolerating side effects. Other times, they just feel better and think they are over their bipolar disorder. When medication is stopped, relapse becomes inevitable.
Every time a patient goes off the medication, within 5 years, majority of them, in fact, have a relapse.
I said, I quit. I'm done with the meds. And everyone was kind of alarmed. I wasn't. After I stopped taking my meds in October, my mood got better and it improved, and it got better, and it kept getting better and better and higher, to the point where I was pretty out of control. It was suggested that I go to the hospital. I didn't want to go, but they pretty much told me, if you don't go, you will be taken.
Compliance is a significant challenge in bipolar disorder because patients with acute mania, especially those that have the so-called euphoric mania, don't want to get treatment because they are happy, they're enjoying the state, so they don't want to come down.
The challenge is let them know that each episode of bipolar disorder that they have worsens the underlying disease state. Now that disorder is harder to treat. The medication that worked for you before might not work anymore, or I need to use a higher dose, or I need to use another medication along with it.
It became a war. It was my way or the highway, and I said, I'm gonna do it my way. And I'm just gonna get off these medications and prove everybody wrong. Just completely do away with medication and say, I'm gonna prove the world that I don't have this disease. Until finally I got manic again. I said, okay, maybe I do have this disease, so let's try to make this work.
By taking this medication doesn't mean you're weak. It actually means that you're strong and that you have insight.
I'm really happy with the medication, like I said, because now I'm working with the doctors. Now I feel that we're on the same team rather than we're on opposite sides of the ball.
In an attempt to self-medicate, many people with bipolar disorder will also abuse alcohol or drugs. This can complicate the illness and interfere with recovery.
I didn't know why, but I actually drank 12 beers in like 4 or 5 hours. And then I thought, oh, I got to get more beer. And I went, I got more beer. And I drank 20 beers that night. I stayed up till 2 in the morning. And then I only slept for 4 hours, right?
Today, advances in the treatment of bipolar disorder include new medications and new uses for existing medications. These advances can mean less risk of relapse and fewer side effects. With the right treatment, many individuals with bipolar disorder can lead full, productive lives.
With these newer medications and providing a solid foundation for our patients to actually do better, our goals are for them not to lead a life because of bipolar disorder, but in spite of it.
I don't believe that medication that helps me to become more stable and balanced takes away my creative flair, my sense of humor, or anything like that. I know for a fact that I can still laugh, I can still cry, and I can still be all of the things that make me me.
Bipolar disorder can be a devastating illness, but today it does not have to be. Today, there are reasons for hope.
It's not the end of the world, and it doesn't make you any less of a person or of a success. You just have to adjust. You're gonna change your life, and you're gonna move on, and you can still do everything you want to do.
I see myself becoming more healthy each year. I'm becoming clearer and able to do more things. I'm taking classes. I'm trying to learn again.
I feel as though I can actually go out and accomplish the goals that I've always had.
I'm looking forward. I'm not looking back too much.
I feel like now that I finally got the diagnosis, the sky's the limit. Set me free.
Lady Alvarado. Hola, Lady Alvarado.
Profe, yo tenía problemas con la conexión.
Karen Contreras.
Buenos días, profe.
¿Cuál es tu opinión del video?
Profe, es muy interesante cómo pues estos trastornos le pueden afectar a la vida de las personas y no solo a ellos, sino a los que los rodean y pues la importancia de el adecuado procedimiento, intervención y pues darles el trastorno, el diagnóstico correcto.
Se parte del diagnóstico correcto para poder abordar un tratamiento adecuado, para poder generarle pues como la ayuda al paciente en su momento. Porque pues fíjense cómo la parte química del cerebro pues está generando una serie de conexiones totalmente inadecuadas que conllevan pues a sus estados depresivos. Por eso es el uso tan importante del medicamento. El medicamento es necesario, pero yo tengo que decir de que pues, no solamente es el medicamento el que fortalece el tratamiento, porque yo tengo que generarle en el paciente precisamente una serie de herramientas conductuales para poder enfrentar toda esta serie de situaciones tan adversas que hay en la mente de ellos, de los pacientes con trastorno afectivo bipolar. Son necesarios los medicamentos, pero tienen que ir acompañados de un tratamiento más con psicología. Ustedes saben que como psicólogos nosotros, aunque conocemos el uso de los fármacos, conocemos cuáles se utilizan, conocemos qué es lo que puede estar generando, nosotros no los podemos formular, no se formulan por parte de nosotros los psicólogos. Pero sí es necesario remitir a psiquiatría en el caso que sea necesario, o a neurología, o a medicina general, para que nos acompañen en el proceso terapéutico con medicina. Pero no nos soltamos nosotros, no nos soltamos de la mano desde la terapia cognitivo-conductual, porque necesitamos enseñarle a ellos una serie de herramientas para eso. ¿Algo que quieran preguntar? ¿Cuál es tu concepto, Saray Niño, por favor?
Profe, pues como decía también mi compañera, cómo abordaron este tipo de trastornos, lo delicado que es saber diagnosticarlo y el acompañamiento me parece que es lo más importante, como estar resaltando en las personas que independientemente que tengan este tipo de trastorno, eso no las anula. Entonces, el video me pareció muy interesante frente al tratamiento y cómo lo abordan.
Listo, Saray, gracias. Margarita, ¿cuál es tu opinión? Margarita Fuentes.
Sí, profe. Bueno, realmente pues ya mis compañeras fueron, digamos, a hablar sobre el tema de cómo se debe abordar el tratamiento, que fue interesante, pero como manera de conclusión también podemos decir que muchas veces se usa la palabra bipolar como si fuera muy normal. Realmente muchas veces decimos, usted parece bipolar, esa conducta bipolar, y pues realmente me parece que no de esa manera. Si podemos observar el video en el abordaje y cómo se debe manejar este tipo de trastorno, pues es bastante complejo. No solamente es de decir que la persona tiene cambios de conducta de un momento a otro, sino que tiene otro tipo de conductas que afectan a la persona y que no solamente afectan a la persona, sino también a la que están con ellos. Entonces me pareció interesante eso.
Gracias, Margarita. Me gustó tu intervención. Muchas gracias. Juliet Díaz, ¿cuál es?
Gracias, profe.
No, a ti. Juliet Díaz, ¿cuál es tu opinión?
Sí, profe, pues muy interesante, pues, como la importancia del acompañamiento oportuno a estas personas, pues, para que sus vidas sean funcionales. Y pues con el tratamiento interdisciplinario, como decía en el video, con la medicación, el apoyo familiar, social, pues para que las personas no se sientan como excluidas.
Para que recuperen su funcionalidad, ¿no? No es que no sean funcionales, simplemente tienen que recuperar su funcionalidad que se había venido perdiendo precisamente por los estados de ánimo tan variables que no les dejan ser como realmente son. Gracias, Juliet. Paola Guerrero, ¿cuál es tu opinión, Paola? Paola Guerrero. No, se retiró. Juan Pablo, ¿cuál es tu opinión, Juan Pablo? Juan Pablo.
Bueno, en el video se observa, además de todas las indicaciones que han dicho mis compañeras, se observa cómo esta enfermedad de orden biológico afecta las relaciones con los demás, y yo digo que además de empezar el tratamiento con esa persona, también empezar a brindar y capacitar a las familias, a las redes de apoyo, para que logren, digamos que, contribuir a esa funcionalidad del individuo.
Sí, claro. De hecho, cuando se menciona Juan Pablo menciona las redes de apoyo o la parte familiar, pues se esperaría que alguien que esté cercano a la persona que tiene o al paciente que tiene un trastorno afectivo bipolar, un TAP, pues realmente sea alguien que le apoye, ¿no? O sea, yo no podría acudir a una persona que está mucho más depresiva que yo o que está mucho más maníaca. No, no podría yo, pues, como tener realmente una orientación. O sea, por lo general se tiene que vincular con personas que realmente le brinden un acompañamiento, una orientación, una solución o que nos enseñe a solucionar ciertas dificultades, porque si nos hacemos al lado de las personas que están igual de mal a nosotros o peor que nosotros, pues, lógicamente pues no vamos a ver los cambios necesarios ni tampoco oportunos. Y lo que hacemos nosotros es pues, generar pues, mayor problemática en mi cotidianidad. Bien, creo que terminamos por hoy la clase. El lunes vamos a comenzar entonces con la presentación de los casos. Por favor, manéjenlos bien, no se centren solamente en la patología como tal, sino diseñen, estructuren el tratamiento que se está estableciendo allí, socialícenlo, desmenúcenlo y compártanlo, por favor. Creo que vamos a seguir el orden que tenemos en la lista que tú tienes, Valerie. Tenemos, ¿no? Eso no quiere decir, y ojo con esto, por favor, no quiere decir de que si ya se presentaron, entonces se van de la clase, ¿no? Tenemos que estar todos allí muy atentos, no sea que de pronto me dé por preguntarle algo a alguien y no esté. Entonces, la medida que yo esté preguntando y no estén, pues, lógicamente eso va a afectar la nota. Entonces, les pido el favor de que permanezcamos en clase, tanto el lunes o martes, para poder abordar cada uno de los casos. El tiempo que cada uno tenemos de presentación del caso, pues no puede ser más de 6-7 minutos por persona, por grupo, para que sepamos qué es lo que tenemos que manejar en ese tiempo. Entonces, señoritas y caballeros, muchas gracias por su presencia, por su participación, para los que participan. Y bueno, nos veremos entonces el lunes. Que pasen un fin de semana muy chévere, muy tranquilo, con mucho autocuidado. Y recuerden, nada de fiestas clandestinas.
Gracias, profe.
Gracias, profe.
Chao, que estén muy bien.
Muchas
Chao.
gracias, profe.
Que estén bien, chao, que descansen.
Gracias, profe.
Valerie, ¿cómo vas con el observador?
Marcelador. Está al día, profe.
¿Vamos al día?
Sí, señor.
Bueno, señorita, muy amable por tu gestión.
Sí, señor.
Muchas gracias, Carolina, por tu presentación. Me hubiese gustado que hubieses manejado el caso como tal, que te hubieras centrado en el caso, que es lo que yo quiero que hagan el lunes, por favor.
Gracias de todas maneras por su paciencia, profe.
No lo digas de todas maneras. Seguramente pues, tienes que reconocer que hay muchas cosas muy favorables en su merced y que estás en proceso de aprendizaje.
Sí, señor.
Listo. Señoritas,
bueno, muchas gracias.
Señora Milena Martínez, muchas gracias por asistir a clase, señora Milena.
Gracias, profe.
Que esté muy bien, hasta luego. Chao, Valeria, que esté muy bien. Chao, Juan Duque.
Chao, profe.
Margarita Fuentes, Juan Pablo, Vicky, todos.
Chao, profe.
Chao, que esté muy bien, chao.